Alliance Academy so far?
Yes, yeah, it's a great school.
How many students?
I'm not entirely sure. Mother, do you know?
No.
It's we are a smaller school, that's for sure, compared to because we opened, I think 5 or 6 years ago was our first time
Yeah.
we opened. But so we are one of the smaller schools, but we're definitely growing. Like there's a lot of like interest coming
Yeah.
to our school.
And it's more of like a lottery based system, and like so people only apply if they want to go. Um so yeah, and a lot of, at least like my brother like got into Alliance Academy, and a lot of his friends are like, oh, I don't want to go there because it doesn't have sports,
Yeah,
and they're like not interested in it. And also they like prefer like a traditional high school experience, so they go to like their districted high school. So I think the sophomore year has like 270 students, like in total sophomore year, like the class of 2025, but I don't know about the other.
it should be around this.
Okay.
Yeah.
Well, that's not too bad.
Yeah,
But you can still do sports at other schools, can't you?
I don't
Mm,
I don't think you're allowed to.
Oh, so I thought whatever school district you lived in, you could do sports there, but still do
I think
class.
it would have to be like club sports if you really
yeah.
want to.
And also, if you have like, if I know some people do like private sports, so you can still do that because it's not like school related. But a lot of the schools, at least like most of my friends, they said that they're not allowed to be there because their districted school said that they don't get like funding or something. Um, so yeah,
Well, that's too bad.
yeah.
Welcome everyone to our February guest speaker with Dr. Oris. So we'll get started in a few minutes. So just feel free to say hi in the comments.
Welcome Alliance hosted members to our to our February guest speaker with Dr. Oris. Good evening, I'm Madhu. Just to introduce myself, I am one of your sophomore council members and I'm stoked to be here tonight.
Hey guys, I'm Rutu and I'm one of your committee leaders, and I'm also very excited to have you guys here and have everyone meet Dr. Oris. So just as a reminder, we will have a QR code up at the very end for attendance, so make sure you stay the entire time.
Should I introduce myself?
Oh yes, go ahead.
Oh, I can. Hey, I'm. Thanks for inviting me to come on board here. My name's Gary Oris. I'm born and raised right here in Atlanta.
Thank you so much for
We're happy to have you here. But before we begin, I'd like to briefly introduce our CTS organization to any of our new members. HOSA is a student-led healthcare organization that strives to prepare students to be the future of healthcare. Through Alliance Academy's host a chapter, we bring you monthly guest speakers with a wide range of specialties and from all around the globe.
Yeah, so now without further ado, we can go ahead and get started. So again, thank you guys so much for joining us. Again, thank you, Dr. Orris, for agreeing to be here. So we'll go ahead and start off the discussion with Dr. Orris. And then you guys, if you have any questions along the time, you guys can go ahead and type them in the chat box. So that's all, the floor is open to any questions. So Dr. Orris, you can go ahead and begin by just introducing yourself and telling the members a little bit more about your field.
Well, currently I'm doing primary care in Cumming, Georgia. I initially started out in emergency medicine, did that for probably 25 years, and realized that the night shifts, the weekends, was getting a little older, and me getting older, I didn't like the night shifts quite so much. So I was looking for a transition and started doing primary care. I took over a primary care practice, which wasn't very big at the time, and we've grown it from there. So I've been doing this since 2004, I think is when I actually started, and kind of grew it up. It was in Roswell initially, moved it up here. And so we, as I was telling the staff here, that I'm kind of a primary care on steroids, because I use my emergency medicine background, and then carry a lot of that over into the primary care office. We do procedures as far as joint injections. We do dermatology. We do biopsies, as well as excisions of moles, IV fluids, IV antibiotics. We have x-ray. I treat fractures. I had a little guy come in today with a foot fracture. So I'm comfortable with treating those and not having to get an orthopedist involved. If they require surgery, I'll get them involved, but a lot of times I don't. And I've actually started 5 years ago, I think it was 2018, started doing what are called vein ablations, and that we treat varicose veins. And you've seen all the commercials and all the places around that treat veins, vein centers. Well, we do that too. That's using my emergency medicine skills and background. It's very easy. In emergency medicine, you get to do a lot of procedures. And the difference with that is, in the ER, you're doing procedures on people that are trying to die on you. So there's a lot of pressure. You have to be quick. You have to be accurate. So I still enjoy doing the procedures. I just don't have the stress that's associated with that right now.
And since they are similar, emergency medicine and family medicine, but how did you go about making that switch in your fields?
Well, actually, I did continue doing emergency medicine for another, I guess, 12 years or so past starting this, because I needed to pay the bills while I got this going. But it was actually pretty easy. 75% of emergency medicine is really kind of primary care, dealing with sore throats, coughs, sometimes with blood pressure, sometimes with diabetes, those kind of things. So it wasn't as hard a transition as I thought it was going to be, because I wasn't trained during medical school and residency, I did some of those things, but for the most part, I was trained in how to handle things after the problem occurred. And so now I'm trying to prevent the problem from ever occurring. Yeah. So it's I've come 180 degrees trying to, different perspective of medicine. And so it really has given me a lot better view. My visual field with medicine is a lot different. I've seen it from a whole different perspective.
Mm-hmm. You saw it from both sides.
Yes.
Yeah.
And so, but like I said, I enjoy what I do now. I enjoy medicine. I enjoy people. And I will admit, one of the things I like about primary care is I like people. I like meeting people. I like getting to know people. In the emergency department, if you get to know somebody, that's a problem. You're having somebody come to the emergency department way too much. But I look forward to people coming in, and they know me, I know them. They ask about my kids, I ask about theirs, and it's just a really a nice perspective, especially as I've gotten older. When I was 20, 25, out of medical school and residency, I was gung-ho, bring in the traumas, gunshot wounds, great, stabbings, wonderful. Right now, I don't need that. I get a gunshot wound every once in a while, really a BB gun maybe, but not a gunshot wound. But still, I think the fact that I get to know people and interact with them, that's the fun part of primary care.
Yeah.
Because you really do get to know them, and you see how much people trust you and your decisions, and I learn who I can trust to do what I ask them to do and to take care of themselves the way they should. Because that,
The stress level kind of allows, like the lesser stress of the primary care allows you to actually go about those conversations.
oh yeah,
Yeah.
I mean, you try in the ER, yeah, there's stress, but you deal with it
Mhm.
and kind of just push it to the side and just keep going. So you still I still enjoyed myself in the ER.
Right.
I had great time. It was a lot of fun,
Mhm.
even with the stress level of how sick people could be. But it's like I said, I was younger, and right now to be able to take a slower pace and get to know patients is a lot of fun. I don't do as far as hospital work. I don't do much of that. Like if someone gets admitted in the hospital, we have doctors that are considered hospitalists, and so that's their job. They work just in the hospital. One of my patients goes into the ER. That's who admits them. That's who takes care of them, and then they send them back to me, where I can take care of them after the hospitalization. I'll still go visit them and see them in the hospital and make sure I agree with what's being done.
Mhm.
But that takes away, because 30, 40 years ago, the primary care doctors would have to leave their practice, go to the hospital, admit the patient, then go back to their practice and finish up. And so that was pretty tough. So I've actually got it pretty easy from that standpoint, where I don't have to leave the practice, go to the hospital, admit somebody, and then try to catch back up again.
Mhm.
So another question I had was, as you said, you were in emergency medicine and now you're in family medicine. Was there anything else you saw yourself wanting to do?
Yeah, like I mentioned earlier with y'all, orthopedics was my objective. My only experience was working at Kennestone Hospital in the operating room, and I just thought the orthopedic procedures were cool. I mean, you got to use hammers, chisels, you got to put back together broken bones, and those guys just seemed to really enjoy what they were doing, and so that was my big deal when I got to medical school. I was going to be an orthopedist, and then I realized that specialty, even though it's fun and I enjoy doing orthopedic stuff in my office,
Mhm.
it's too limited, and that they get so. I actually joke with orthopedists that they're not only a shoulder specialist, but they're a right shoulder specialist, and that they really don't know anything else about the human body except their joints that they're taught to work with, and that's not what I wanted to do. And that was kind of a big awakening during my junior year of medical school, that this isn't who I want to be long term. And that's when I started looking at something. My personality, I like variety. I like to see different things, and so that kind of limited a lot of the specialties, because Raju, you mentioned ophthalmology. Could I do just eyes the rest of my life?
Yeah.
And you got to look at it that way. What do you want to do the rest of your life? Do you want to be a gastroenterologist, and do you want to be a cardiologist, just deal with the heart and blood pressure the rest of your life? And so I just knew in family medicine, which is my first diversion, I said, that's a variety. I get to do a lot of different things. Kids, adults, men, women, doesn't matter. I'll be able to do everything. And that's when I found out about emergency medicine, because at MCG, Medical College of Georgia, where I was in school, they didn't have an emergency medicine program at the time. So I didn't know about it. And I was actually at Atlanta Medical Center at the time. It was called Georgia Baptist. And they had emergency medicine physicians that were trained in emergency medicine. And I just thought, well, this is kind of intriguing. So I went down to the ER and hung out with those guys and observed them and talked with them. And they kind of just gave me their perspective. And I thought, that's pretty cool. You get to handle the sickest of people in the worst scenarios. And so I felt like I would be doing the most for a patient.
Mhm.
And in the first, that hour they're in their ER, you're probably doing more than anybody in the whole hospital the whole time they're there, and you're doing it quick, and then you pass them on to be admitted, and whichever specialty would take care of them. So I thought that was pretty interesting, and that I was hooked, and that's why I headed down that path. So I encourage anybody that's who they are, if that's their personality, to consider emergency medicine, because it's fun. If you like doing procedures, it's a lot of hands-on.
Yeah.
And you can't be afraid. If you're, I can tell you a little story. I had a patient in the emergency department, and I was at a teaching hospital, and I had residents, and this patient needed to be what's called intubated, and we needed to put a tube in to breathe for them because they were struggling and weren't. I could tell within the next 30 minutes they were going to stop breathing if we didn't do that for them. So I told the residents, the senior resident there, I says, "Hey, I want you to do this, and I'm right here. I'll help out." And he was too scared to do it. And these were internal medicine residents, not emergency medicine. Emergency medicine residents would have grabbed it and done it before I even asked them. But I even asked the junior resident, "Are you interested in doing this?" And they didn't want to do it. And finally went to the intern, who's the first one out of medical school, the youngest of them. And he said, "All right, I'll step up. I'll do it." And he did it. And you got to, anything in medicine, you got to be able to handle whatever scenario might be going on. And that's what I was trying to reinforce with these guys. If you're on the floor at night, you're the only guy there, and a patient stops breathing, you got to be able to do this.
Yeah.
So
Make that call.
yeah. And so if you right now, this is the perfect scenario. I'm looking over your shoulder. I won't let anything bad happen. So this is where you learn. This is to take an opportunity of this. And actually 2 of the 3 weren't ready to do that. I'm not trying to scare you out of medicine at all, but I think if y'all go into medicine that you're under that scenario, I'm sure you would handle it without any problem.
Mm-hmm. So I was kind of wondering, what does a day-to-day look like for you?
Right now?
Yeah, right now. And then kind of compare it to what it looked like when you used to work in emergency medicine.
Well, right now it's of course everything for the most part scheduled.
Yeah.
I probably have 20 patients that are on the schedule before the day starts, and we leave slots for people to walk in so that we kind of function as primary care and urgent care to some degree. Mm-hmm. So I may see 25 to 30 patients a day, depending on what's going on out there, for people getting injured, people getting sick, and what's going on. So, but it's a set routine. It's a schedule where I'll go see patients, and I get to take my time at lunch, and then we start back up at 1 o'clock and see patients till 5. So it's very set. In the emergency department, I may be doing this, sitting, doing nothing for 3 or 4 hours, and I may be there and not sit down for 12 hours or 8 hours, depending on how long the shift is. So it's a very different. I mean, you just basically, whatever walks in the door in emergency medicine, you handle it. You take care of it. Whether it's a sore throat, gunshot wound, stab wound, overdose, dizziness, abdominal pain, whatever it might be. Like I said, I like the variety. And so you got to be able to handle it and decide within a short period of time, is this bad? Is it nothing? Is it constipation? Is it appendicitis? And so you get to use all your skills all day.
Yeah.
And on Tuesday, Tuesdays in the office is what I call my vein day. That's when I do the vein procedures. Mm-hmm. So that which is a nice change of pace. Like I said, I like variety. And so we'll have scheduled vein procedures, and they each last about an hour.
And I knew you were kind of talking to me about the vein procedures. Could you kind of go more into depth, because that sounds pretty interesting?
Oh, okay. So I don't remember if I mentioned, but we varicose veins, which are veins that have failed and no longer working. So when you stand up, blood starts to pool down in your legs, and the veins start bulging. If you it's not hard to spot. Now that it's warming up, you'll walk around and you'll notice people with bad veins in their legs. Mm-hmm. Well, I treat those, and so we do ultrasound. Using sound waves to diagnose it. We use ultrasound to do the procedures, and I'll will close those veins in the office using a catheter. And it's a very simple procedure. It's very low risk. It's just dealing with veins. And like I said, it's a procedure. It's fun to do. And it gives me a little different variety.
Yeah.
And I'll see patients on the other side of the office. If somebody walks in sick or something, I'll try to go back and forth taking care of those things at the same time. What else can I add to?
Yeah, so we actually have a member question from one of our members. Are there any emergency medicine physicians similar to intensivists?
Essentially, yes. Intensivists are the doctors that work in the ICU. And so, you know, they get to do a lot of procedures. They do the intubations, like I mentioned. They do put in IVs in deep veins, which are called central lines, to help take care of patients that got the monitors. So they take care of the sick patients like we do in the ER over a longer period of time. And so, like, if someone comes in the ER and they're breathing okay, and then they stop breathing on the floor, then the intensivist, they've got to be skilled enough to be able to put the tube in to breathe for that patient. And, you know, they'll have different medications. If it's a heart patient and their heart's failing, they may have to put them on different medications through an IV to try to keep the heart pumping. And so they've got to be able to, they do a variety of things in the same sense. They're typically pulmonologists, I think, are most of the intensivists. So they got to be able to manage the heart. They got to be able to manage the lungs. They got to be able to manage, you know, whatever else might be going on, depending on what the problem is. If it's an infection, they've got to be able to help manage that too. But usually they'll have other doctors, specialists. If there's an infection, they'll get an infectious disease specialist to help them out. If they're cardiologist, if it's a heart problem, the intensivists are kind of the quarterback to the team in the ICU. But they'll still get the specialist to come in and help them out to, you know, monitor a patient and take care of them and make decisions. So it's kind of becomes a team effort. And not saying you know, if I have a patient having a heart attack come in the ER, I'm going to get a cardiologist involved pretty quick with that if they need to go to the cath lab. My job is primarily to stabilize quickly and then get them to the specialist. And if it be a heart attack, it'll be the cardiac ICU, which the cardiac intensivist. I think the intensivists, for the most part, work in the CCU as well as the ICU on both sides, depending on what's needed. So, yeah, I would say there is definitely a similarity there.
Yeah.
So earlier you said that you like the variety of family medicine, like you treated men, you treated women, you treated children. So one of my questions was like, how did you like start, like, for children? Every medical professional I've talked to so far that has dealt with children, they always say they handle them in like a specific manner, like make them comfortable, because children tend to be scared of the doctor. How do you deal with children?
And the children are easy. It's the parents you got to watch out for. They're the ones that can be more difficult. But you're absolutely correct. Whoever told you that knows treating kids very well. And so whenever I walk in, I will focus on the kid. I'll introduce myself to the parents, but I always focus on the kid. I want them to interact with me because that's part of my assessment. You know, if the kid's not interacting, okay, that's important. He's sicker than I think he is. Mm-hmm. But I'll do simple things like it's funny how kids are with their shoes. I will actually start playing with their feet and their shoes and make comments about their shoes. Mm-hmm. And you can just see their whole complexion change. They're like, well, this isn't a doctor. He cares about my shoes. And you can just kind of see how their whole demeanor and how they start smiling and they start making good eye contact and they interact with you. And so, you know, or if they have a toy with them, I'll comment on their toy and play with their toy with them. And just it really doing something like that and connecting with the child. Number one, it helps me assess them. I can get a better feel for how sick they really are. Because the kid that won't look you in the eye, that's a sick kid. And you want them to be able to interact. And if you get them, if they're not comfortable with you trying to examine their abdomen, it's not going to be easy. Mm-hmm. And so just and I'll spend 5 minutes, 10 minutes just trying to improve that rapport with the kid so that they are comfortable with me. Mm-hmm. But I don't feel like I've ever had trouble with kids and interacting with them because it's important. You got to be able to have that interaction. You can't go in cold and just talk to the parents and only acknowledge the parents and expect the kid to interact with you. And one of the things I used to do, depending on what's going on, I used to keep frozen popsicles in the freezer in the ER, and I'd go grab one of those and bring them in there and give them to the kid, and all of a sudden they love you. And so it depends on what's going on if you can do that, but you just want them to trust you and allow you to interact with them. They want to trust you. I don't think if they've had a bad experience in the hospitals and the doctors getting shots, you don't talk about shots. You just basically interact with them and get down to their level. I'll sit on the floor if I have to, just to, make them feel like I'm a good guy, not a bad guy. So that's a great question.
Kind of like I'm thinking about like the difficult patients, the one who tried to like don't really want your treatment or try to refuse treatment. Do you see that more in adults or children?
Kids I don't see that with kids much.
Okay.
If there's the only time is it's not the kids, it's the parents that are the problem, that they allow their kid to say no. And that's wrong. That's bad parenting, in my opinion. The parents should be there to take care of the kid. For instance, if I wanted to give, say they have a fever and I wanted to give them some liquid Tylenol, if the kid says no, then, I expect the parent to step up and help and make sure that this happens versus getting out of the way and expecting myself or the nurse to have to do it. I expect them to be, agreeable and have the parent help out. So I don't blame that on the kids. Now, adults that refuse care, my job at that point is to educate them, make sure they understand why we want to do what we want to do, what we're trying to accomplish. It could be that they're scared also. Right. And so I want them to be comfortable with the situation, that everything's okay, that this is why I'm doing it. I'm not doing it because I want to hurt you. I'm not doing it because I'm trying to make money. I'm doing it for this if I can't give a good reason for why I'm doing it, I got to be able to answer that.
Yeah.
And so that I've got to be able to say, this is why I'm doing it. And if we don't do it, this is the consequences. And as far as I'm concerned, if they're over 18 and they want to refuse, you're an adult. As long as they're not overdosed on sedatives or alcohol or out of it for whatever reason, I'm not going to fight. I said, you're an adult. If you understand you're having chest pain, I think you're having a heart attack, we need this test to be done, and you don't want to do it, you're responsible for yourself. And so, I hate it, but I do my best to try to convince them. But they have every right to leave the hospital as an adult if something's going on. Now, if a kid, if they're bad sick and I think they need IV antibiotics and be admitted in the hospital, and the parents are like, no, we don't want to do that, I may have to intervene and get the authorities involved, because to me, the parents they're not functioning in the best interest of the child.
Yeah.
And sometimes I'll get another physician to even step in to make it look like it's not just something I want to do. It's something that, is agreed upon by more than one person.
Yeah.
But anytime you want the patient on board.
Got it. Here, we have another one of our members asking a question. Is there any opportunity for emergency medicine physicians to rotate at multiple hospitals for a change in setting? Because I know you were talking about kind of like different.
I assume that as a medical student, you can work at different hospitals as part of your rotations. As a resident, sometimes you'll work at different hospitals. And then once I got out, when I first moved back to it, I did my residency in Winston-Salem, North Carolina. When I moved back to Atlanta, I was working at Gwinnett Medical Center, Douglas General, Cobb Medical Center, Northside Hospital. It seemed like there was another one. So I was working at a bunch of different hospitals just to see, which one I liked the best and which one treated me the best, which one paid the best, which one, treated the patients the best. What was the hospital staff like? Because you really become part of the hospital when you work there. So yeah, there is opportunity at any time to work at different hospitals. And I think that's good to see how different hospitals handle things.
Yeah, again, just kind of getting that variety and like kind of see what actually like suits you.
Sure, sure.
We also have a question that says, is there any reason why parents might send their kids to a family medicine doctor over a pediatrician? And
That
also,
would be
can you explain? I'm sorry.
the
Can you explain the difference between?
sure. So for family medicine is, as the term implies, treats the whole family.
Mhm.
From and back in the day, I don't think it happens so much. Well, maybe in rural Georgia or rural areas they might. Family medicine physicians would even deliver the babies. So they would take care of mama through the pregnancy. They would deliver the baby, and they would take care of, you know, all the children, all the adults, even the geriatrics, the older patients. So they cover everybody. Um, Pediatricians, strictly pediatrics. They handle only kids, and usually when they start getting into their mid-teens, they pass them on to either a family physician or to an internist at that point. But a preference to me, it would be just preference. In my office, we don't do childhood vaccinations. I don't see enough kids to warrant buying all the vaccines because they're not cheap. So that's an advantage of seeing a pediatrician. But both specialists, they're both trained in taking care of babies, taking care of infants, taking care of adolescents, the whole gamut. And so that would be just apparent and what opportunity they had available. I think I read this morning that there is a big time shortage of pediatricians in rural Georgia.
Oh.
I think CHOA's given a whole bunch of money. Anybody wants to be a pediatrician out there, CHOA's given a whole bunch of money to pay for scholarships for medical school for those that want to commit to being a pediatrician.
Oh, really? Yeah,
Yes.
I heard that. I didn't hear about that.
That was just this morning on the radio. So
Mhm.
that unfortunately, I hate it that there's a shortage.
Right.
But it's nice that they're trying to get a commitment to help out with that.
Mhm.
I heard that too. I heard that like not a lot of people wanted to be pediatrists, so CHOA was encouraging people. Yeah.
And you gotta love kids to want to be a pediatrician.
No, yeah.
I was wondering, as you've gone through both your emergency medicine background and your primary care background, was there any like specific, like what's the most memorable case that you can kind of like remember?
Oh gosh. In emergency medicine, there are a lot of them because, like I said, you get your stabbings and gunshot wounds. One of them, y'all probably don't remember, and I can't remember what year it was. There was a mass shooting in Buckhead. A guy walked into. He was a day trader, walked in and just started shooting all the people in this building. And so we got, I think 3 or 4 of them came to. I was at Northside Hospital, Atlanta at the time,
Mhm.
and so those gunshot wounds came to us. 3 or 4 of them. Some went to Grady, some went to Piedmont, a couple went to St. Joe's, and so it was tough because we had one guy that was shot at least 4 times, and then we had a girl that was shot once. And believe it or not, she was the worst of the 2. And so I'll never forget, dealing with him, thinking he was going to be the problem, when actually he did really well. And the girl, she was doing great at first, and then 5 organs were injured with the gunshot that she took in her abdomen, and it had hit one of her inferior vena cava, which is a big vein in your abdomen, and she had a lot of bleeding. She went to the operating room, and it was a very difficult case talking to the surgeon afterwards, because it had just shredded the vein, and they had trouble trying to put it back together again. But the other guy that was shot twice in the chest, and he was just very lucky that the bullets, didn't hit a major vessel, or so he didn't bleed, but it hit his lung, both on the left side, and I think he had 2 shots in his abdomen. So he ended up going to the operating room too, but he did great. So just the fact that it was what happened in Atlanta, that we were at Northside, and Northside Atlanta didn't handle much trauma because Brady downtown, and at the time Atlanta Medical Center down there, our trauma center, we didn't get as much of it. So that was kind of a memorable thing to have 2 of those gunshot wounds come at the same time, and news that was, of course, it was all across the country talking about what had happened. Memorable case here. There was an interesting one that I had that I thought I was kind of proud of. I had a guy, and this was before Northside Cumming was doing more cardiac stuff. They didn't really do much up here at the time, and it's probably been 10 years maybe. But I had a guy walk in my office, and he didn't look great. I diagnosed him as having an acute myocardial infarction, and I was able to contact the ambulance service, St. Joe's Hospital, because that's where he had to go to get treated. And I found out later that he was out of the cath lab 45 minutes from the time he left my office, which, they brag about whether the golden hour of a heart attack, that treating it, you've got to take care of it in that first hour.
Yeah.
And he was already out of the cath lab 45 minutes from after leaving my office. So I was pretty happy about that. So that was and he did great. So that was a very memorable event that happened here.
Yeah.
And the fact that he was able to get down 400.
Oh yeah.
What is the work life like for emergency medicine physicians? Do you work alongside coworkers or independently?
Typically there's more than one of you there, depending on the hour. I mean, usually from 7 a.m. to probably midnight, there's usually at least 2 physicians there, sometimes 3, depending on how busy your emergency department is. But you're working independently, but you're there at the same time. I mean, if you need help, if you want to ask a question or consult with your coworker, hey, what do you think about this? They're available. But for the most part, you're working, by yourself, seeing your patients, taking care of your patients, discharging them with your designated nursing staff and medical assistants and EKG and ultrasound crowd that you got. So it's kind of a dual question, I guess, in the sense that, yes, you work with coworkers that you can get consults from if you want, but you're doing your own work for most of the time.
Mm-hmm. And with many of our members that are watching being high schoolers, what are some recommendations that you might have for those that actually want to pursue primary family medicine or emergency medicine?
Well, now's the time that if you can get in an office just to see what it looks like. And I think a lot of the medical schools require that now.
Yeah.
Where they didn't when I was applying. But yes, it may be required, but I think it's a good idea. I think it's smart because the time that you've got to figure out what specialty you want to do is very limited. And so if you can get out there and see what's going on, and like I said, I wanted to do orthopedics, so my only exposure to medicine prior to medical school was the operating room. So I'm looking at which surgery do I want to do? Because I thought I wanted to be a surgeon, but then I realized I don't want to be stuck in the operating room all the time. But so just a hint, if you think you want to go into family medicine, spend some time in an office, just observing. If you want to do an emergency medicine, spend some time in the emergency department. If you either as an employee, as a scribe or a medical assistant, they're always looking for help. Right. You can see what it's like in there to get a feel for the flow and whether or not that's something you would want to do. If you think you want to be a cardiologist, go spend time with a cardiologist. My son, like I said, he's a sophomore in medical school. I would tell him, he spent time with me in the office. I sent him to spend time with a general surgeon. I sent him to spend time with a cardiologist. And so I'd call up my friends and say, hey, can my son come hang out for a day? And almost everybody's obliging and willing to share their time. And he got to go into the operating room some. He didn't scrub in. He didn't do any suturing, I let him do some suturing, but it, is any exposure you can get is a good idea to try to help get a better feel ahead of time. And whether or not you even want to go into medicine, you may get into it and go, you know what, this I don't want to be a doctor. You could be like my daughter, who doesn't care anything about taking care of people. She wants to take care of animals. She'd rather be a vet, and so that's the path that she'd rather go down. So
yeah, I think definitely, like we were talking about this before, that there are so many like different sectors of healthcare. So getting that exposure can just kind of help you like narrow down what path you actually want to go down.
And healthcare is such a big commitment to all professions are a big commitment, but healthcare especially because you have to live healthcare, eat healthcare, breathe healthcare, like live healthcare. So you need to know exactly what you want to do before you like make a move.
now on the other side, could you change your mind? Yeah, but I will admit, if you go down the healthcare path, I don't know what else I would do if I wasn't being a doctor. So that would have been a struggle for me. I knew I wanted to be a doctor since I was a kid. I just didn't find out till later what type I wanted to do, but I just knew I wanted to take care of people. But I had a guy that was a sophomore medical student who never studied, and I couldn't figure out why. I thought he was just brilliant. Actually, he wasn't brilliant. He didn't care. He didn't want to be a doctor, but he got pushed into the medical field by his parents because that's what they wanted him to do. And so you got to make sure it's what you want to do and that it's in your heart. And if you're not sure, take more time. Take a year off, but after college, before applying to medical school, to feel like that, this is really the path I want to take. I think medical schools would look at that very favorably versus somebody who came, just rushes right through and wants to jump in. That this person really thought about it because they're making a commitment to you. They, as a medical student, they want to pick the right ones, the ones that are going to commit and continue to be doctors, not somebody who's going to give up after 3 or 4 years and change their mind and go do something else. So if you think about it, I think that that's an advantage.
Yeah. I've actually heard like mixed opinions on taking a gap year between undergraduate and medical school. Did you end up taking a gap year?
No. And so, I'd be honest, I almost wish I had. I felt rushed through it, but like I said, I knew the path that I wanted to take, and so I went down that path. But I really wish I wouldn't have mind. Looking back, I wish I'd have spent a couple of years maybe doing military just to have that experience because, or something just to make sure, because you don't feel like you have to rush through to get through and get out. You're in your young years, you're full of life, you got plenty of things to do. Take advantage of it. One of my that was in my class the year before had just gone around the world sightseeing.
Really?
They were just trying to see the world before they decided about going to medicine. And I thought, well, that's pretty cool. If you can afford to do that. I couldn't.
So we actually have another one of our members asking, what would you say to someone who wants to be an emergency medicine physician? And is there anything else that we prepare for those that actually want to go into that path?
To be prepared for ahead of time, or anything we should be prepared for?
I think kind of
like what values would you say a person needs to have in order to be?
Well, like I said, you got to be able to think quick on your feet. You've got to be able to respond in seconds, because sometimes you don't have time to go back and let me go look something up. You've got to be able to respond and use your gut. I mean, and I remember one of my attendings in my residency. The attendings are the guys that are full-fledged emergency medicine doctors. They're out practicing. They're the instructors. And one of my attendings telling me that when in emergency medicine, sometimes you got to go with this more than you do this. You use your gut. You just got to take your gut instincts, take your training. And that's why the residency is so important, to learn and understand. And so if you see this with a patient, you've got to go down this path, and you just got to be able to make quick decisions. So if you want something that you can sit down and think about and ponder, you're in the wrong field. You really don't want to think about that. You got to be able to react quickly, and be able to, communicate with your team, because in emergency medicine, it's a team effort. It's not just me. It's me. It's my nursing staff. It's my MAs, the medical assistants that are there with me. You attack the patient together, and usually you'll have 2 or 3 nurses that you're working with. But anything else to be prepared for? I guess that's it. Just if you have a background in as a paramedic, I see that as an advantage.
Yeah.
If you're interested in emergency medicine, wants get some training there, and I know they do that at Alliance Academy.
Yeah.
That they kind of teach a more basic form of what we do. If you see this with a patient, think this. If you see this with a patient, you think this. And so paramedics have a very good base for what could go on in the emergency department. Mm-hmm. And to me, their scenario is even worse because they've got fewer people helping them, and they're out there in the field trying to get the patient where they may have just gotten shot or it's a bad accident. They're trying to get them out of the car and assess them initially. So by the time they get them to me, all right, hey, great. I've had 2 good guys or girls assess the patient and give me some information so that I don't have, that's already what we call the differential diagnosis, which is the different possibilities that could be going on. They've already narrowed that down some for me. That, okay, this was a gunshot wound, but it's only the abdomen. There's nothing else. Okay, that helps. Or if it's a bad accident, the guy is awake and alert and talking, so it's not a head injury, but he can't move his right leg. Okay, maybe that's all it is. But still, with any, like an auto accident, you have to be able to think of, somebody gets bounced around in a car, they could have something else broken and not realize it. Could their spleen have ruptured? Could their liver be injured? And so you still keep an open mind, but you got to be able to just think quick on your feet, and be confident. I hope that answers the question.
Yeah, no, I think it definitely did. Yeah.
So one of my questions was, you said, this is something I've always wondered, and I'm just asking you, residency, how does that, is that like part of med school? Like, do you get assigned to a certain hospital that you do residency for, or do you have to like search for it yourself, kind of like an internship? I was just confused about that.
Well, internship is your first year out of medical school, and it's part of the residency typically. Like in my emergency medicine residency, it was for 3 years. And yes, I went to Wake Forest, is where the Wake Forest University Hospital. That's where I did my training, and my internship was part of that. Now, in some specialties like ophthalmology, I think a lot of them will do an internship, which is considered transitional, where they do a little bit of everything: general surgery, OB, internal medicine, whatever. But they do a year of that. Then they start their ophthalmology residency, and all they do from that point on is ophthalmology. But residency, what I did, and I think it was a good idea. At least it helped me a lot. In your senior year of medical school, you're going to be given so many electives. And so once I realized I wanted to do emergency medicine, I picked different programs. I didn't want to leave the Southeast. I wanted to stay in the Southeast and do my residency. So I picked different programs that I was interested in, that I thought were good programs for my residency in emergency medicine. And I did a rotation there. I did a month rotation at that hospital. And so I did one of them at Wake Forest. I went to East Carolina. I guess that was the only 2 rotations I did. And so by doing that, they got to know me, I got to know them, and it kind of gave me a good perspective of what, narrowing down where I might want to go. And so when I was at Wake Forest, I fell in love with the attendings there, the chairman, the department, and how it was run. And I just knew that's where I wanted to go. But when you're going through the process, you interview, God, I must have interviewed 15 different places, and you try to learn what you can in one day. Is this really a residency that I want to go to? And did I like the people? And so it's hard to make a commitment. And then the fun comes in March when you do the match. So you basically list the places that you are interested in order of preference.
Mhm.
And I only think I put down 3, and just kind of prayed that I got one of them. And then the residencies do the same thing. They put down who they want in order of preference, and the computer just throws it together. And so I was lucky enough that Wake Forest wanted me, I wanted them, and that was my first choice, and that's where I got to go. But some folks didn't know until that day, and they kind of hinted to me, so I wasn't stressed out at match day. But they kind of hinted to me that they would take me if I put them down. And so, but some people they didn't find out till match day where they were going of one of maybe 10 spots until that day. And some people didn't match. If the coordinates didn't come together with their system, then so they found out that morning that they didn't match, and they would just start calling around trying to find a residency where they were going to do their specialty, whatever they wanted to do. And some of the more competitive residencies, that is when it typically would happen. Ophthalmology was competitive, orthopedics was competitive. I was actually fairly lucky in that I was the only, believe it or not, the only medical student in my class of 180 students that wanted to go into emergency medicine.
Really?
So, the programs in the Southeast wanted a connection with MCG. And so, Grady, they told me, you got a spot here if you want it. And South Carolina told me that. Norfolk, Virginia told me that. Orlando told me that, because they wanted that connection to have one of the students come there. And, the class ahead of me had 7. The class after me had 8 that went into emergency medicine. And so it was a little bit tougher for them. But me, I had it easy. I got lucky.
Another thing is, so if there's like many interns going to a hospital, you said they list them in order of preference. What if there were a lot? Do they just like list like groups, like we want these specific people? Like
That's what the residencies do. Yeah, they list the residents that they want, or the medical students they want, should I say? And like, you just hope that you're one of them if that's your top choice.
Yeah. And so most of the people, do they ever like find like if they do like last minute calling around, are they able to find spots? Or like what happens if you can't find a spot? Do you have to wait until the next year to do it all over again?
Yeah, for the most part. There was a guy at Wake Forest that he wanted to go into general surgery, and he did not get a spot. So he found a spot doing that transitional year that I talked about. So he rotated through general surgery, neurosurgery, ophthalmology, whatever, during his internship. But he would go through the match again the next year, and hope that he matched at that point. If someone really wants to be a neurosurgeon and they don't have what the neurosurgery residency thinks is the qualifications to be a neurosurgeon, you may never get picked. But you keep, if that's what you want to do, you keep fighting and prove them wrong. And a lot of times you'll still get that spot. You got to be diligent. And I, like I said, doing doing rotations at the different spots that you might be interested in sometimes can help. So they get to know you. They want to know who you are. They want to know that they can work with you.
Yeah. Something that I was wondering, I remember kind of towards the beginning of the event, you were talking about how your office just started doing those vein procedures. What other sort of procedures do you do in your primary practice? Because I know you have some experience doing them in emergency care as well.
Oh, well, like I said, we do, moles, where we'll do biopsies on moles. I'll excise moles, and laceration repair, fractures. I'll put them in a cast as long as it doesn't require surgery. If it requires surgery, then I'll get them to an orthopedist. But if it's something I can put in a cast and manage, like the kid this morning who broke his foot, it does require surgery. I put him in. We're going to get away with just putting him in a boot instead of a cast. And I'll manage that, have him come back 3 weeks, re-x-ray it and make sure it looks okay. what else do we do here? Well, like I said, it's a lot of the same stuff in the emergency department. Just I don't have a CT scanner, which that would be nice. But let's see. But yeah, doing the veins, I enjoy doing those.
Did you just start doing the vein treatments?
I started that in 2018.
Okay.
I do the spider veins too. You see people that complain about the road maps on their legs, and so I can inject those also.
Yeah.
Doing that, but it's funny. My son would give me a hard time about doing, like, I remove a mole off somebody's face, and he's like, "Are you sure you should be doing that?" And I'm like, "Well, remember now, I was trained in emergency medicine to put back things that were ripped, torn, or cut.
Mm-hmm.
So I didn't get to make those holes, but I was trying to put them back together again. If I get to make the hole and put it back together again, that's easy." And so it's important to me to make sure it has a great cosmetic outcome.
Mm-hmm.
And that, the greatest compliment is that people can't find where you did the excision.
Right.
And so I just, like I said, using my emergency medicine skills to my advantage here.
Mm-hmm.
I think we kind of mentioned this earlier, but what was your college experience like? Like, not med school, but like undergrad. Were you like very overwhelmed? Was it kind of like you already knew where you wanted to be, or were you nervous that you wouldn't get picked or something like that for med school?
Oh, no question. I mean, everybody, I think, is that way in college. I went to University of Georgia, and yeah, the whole time you're there, you're studying, you're trying to learn. And I'm the kind of learner that I have to make the effort. I just don't absorb it, and it's stuck in there. I have to sit down and spend as much time as I can going over something to learn it, and then so my grades weren't straight A's, but I made good grades, and so I was able to make it in there. I got lucky.
Yeah, University of Georgia is a pretty popular college. I know a lot of my friends want to go there. Yeah.
Something I was wondering is, I remember you saying that you actually work in a clinic right now, like you have your own private practice. How is that like when compared to like actually working in a hospital when you were part of your emergency medicine background?
I actually enjoy it, and that's a very good question. And I think the advantage, and I hate to say it, but I think medicine's getting away from this. I like being my own boss.
Mm-hmm.
And that when I was in the emergency department, I was a member of a group.
Right.
We had, I think, 9 and finally end up with 12 members, I think, in my emergency medicine group. Mm-hmm. And so you're one of the others, and you're also at the mercy of the hospital, because they could dictate whatever they wanted you to do, not necessarily caring for patients, but policies and that kind of thing.
Yeah.
In my office, I'm my own boss. I'm responsible for myself. If I do something that's not right, that's my fault. But that's me that has to answer to that. Mm-hmm. And so I do like that aspect of it, because needless to say, we had our moments where we didn't all agree on something, but now I get to pick the rules and what we do and how we handle things. And even during COVID, the hospital's still wearing masks. In the office, we didn't wear masks. If I had a patient that had COVID symptoms, I met them in the parking lot. I walked out there, and so they didn't come in to expose anybody else. But I got to make that decision. Where if I was a doctor that worked for the hospital, and that was the reference I made earlier, how things are changing. A lot of doctors are now employees of hospitals, and in my opinion, that's not the way medicine should be practiced. The doctors should be responsible for themselves, not answering to hospitals. Mm-hmm. Hospitals shouldn't dictate how healthcare takes place. And so all the other doctors, they're wearing masks the entire time. They're not seeing patients. They closed their practice. They weren't seeing patients in the office, where we never slowed down. In fact, we picked up because we were doing a lot of testing at the same time too. Yeah. But not one of my staff members got COVID from any patient. I actually got it from my daughter on a trip to North Carolina. nobody can argue that we did it wrong because we should have been wearing masks. Well, tell me where there was a compromise. But again, that was a decision I got to make. And I have no regrets with what we did.
And
But, go ahead.
a lot of the doctors that I've talked to that have been in practice, they always complain about like kind of the administration side of it and how they don't really enjoy like the business aspect of it. Is that something that you also like struggle with?
I cheat there. I married a girl that's very good with business, and so she runs the business side of the practice.
Okay.
And so, that's another great question. So I don't have to, as far as the day-to-day running of the practice, taking care of patients, what things, supplies that we need, that kind of thing. I help with that, but we have an office manager who manages 99% of the stuff on getting the supplies, making sure everything's there, making sure the staff is working. And my wife handles the, part of the insurance business. The office manager handles some of the insurance side of it, which is a nightmare. And if y'all go into medicine, that you will learn, the more you get into it, how much you hate insurance companies and how they don't care about taking care of patients. They care about their bottom line. And that can be very difficult. And thank goodness I'm not the one that has to deal directly with the insurance companies, because I would probably quit doing this by that time.
Yeah.
So I get to do the fun part. I get to take care of patients.
Right.
And so indirectly, I might have to deal with insurances, but for the most part, I don't have to.
Well, thank you so much, Dr. Orris, for your time. So we're going to go ahead and close our event. So I want to thank you guys all for joining the conversation and making it interactive. And thank you again, Dr. Orris.
Well, thank you very much. I've enjoyed it.
Yes.
Thank you so much.
Y'all have a great evening. Bye-bye.
Bye.
You too. We're gonna leave the QR code up for like another 30 seconds. To get the credit, you have to complete it by Monday. And this video will also be posted on YouTube channel, so you can come back and watch it later. Thank you guys. Have a good night.